Uh, you're hearing a lot about kidney, and I'm thankful to all of you who are sitting here listening about the kidney because I agree with you, ma'am. We need to protect the kidney. So I'm going to take you a little bit more deeper. If you got bored by what Arvind was saying, then I think you can leave and go for a cup of coffee. Because I'm now going to go into much deeper into a clinical trial. It won't be a general talk which Dr. Manish gave. It will be much more deeper. How do you define CKD? You already heard it, but see, I go back to my MBBS days. I read a chapter once, I only remembered 8% of it. I read a chapter second time, I remembered 14% of it. Only after reading 10 times, I could only remember 40% of it. So I think revision helps. So some of the slides will be common, you've already heard, but I think I'll present them in a different way, so it'll stick. Two things are required to diagnose CKD. You need to measure a creatinine, calculate EGFR. I mean, we say calculate EGFR, but I'm sorry and sad to say, you just ask yourself, how many times do you write EGFR in your prescription? Please ask yourself. We don't write. We give lectures here. Even ma'am was saying primary and second tier, two tier cities. Even there, people don't write EGFR. Go to teaching institutions. Go to PGI Chandigarh. Not every time EGFR is written. And next is ACR. It's such a simple thing to do. You'll be surprised. Just read the Indian data, how many times it's done. So GFR less than 60, ACR more than 30, both lasting for more than 3 months. That is CKD. So because the definition is this, that's why what ma'am said, prevalence is anywhere between 25 to 45 to 50%. Depends where you are choosing your patient population from. You come to a tertiary level hospital, Osmania, maybe 50 to 60% of the patients have CKD. You go to a village, you go to a primary care physician, maybe 10-15% have CKD. How to screen for CKD? So simple. Still not done. Check a serum creatinine and calculate a EGFR. Please use CKD EPI formula, as ma'am said. I'm just stressing it so that we remember again. And do a ACR, albumin creatinine ratio. Who to screen, when to screen, you know. So now I'm diving into my topic now. Optimizing care in a person with type 2 diabetes. All of us in this room except ma'am should be concerned with primary prevention. Your job is to make sure she does not see any patients. But we but we fail. We fail. There are only 4 things to do, yaar. Glycemic control, blood pressure control, lipid control, lifestyle intervention. इसमें कौन सी बड़ी बात है? क्यों फेल करते हैं हम लोग? Except madam, all of us are responsible. We are increasing our workload. She can't do so many renal transplants. Yeah, come on. Don't send patients to her. अरे बाबा मेरे बोलने के बाद भी लोग ये ये मैं पहली बार थोड़ी बोल रहा हूं, ये मेरा 100वीं बार बोल रहा हूं लेक्चर. उसके बाद भी मैडम ने क्या बोल रहा है? इट्स ऑल इंक्रीजिंग. Look at this is what you and I are doing. We should all hang our heads in shame, except madam, she's a nephrologist. Look at the HbA1c control less than 7% in India, 1 in 3. क्या बकवास? GLP-1, finerenone, SGLT2. 1 in 3 in India have HbA1c less than 7%. Just get less than 7%, at least 30% of patients will be reduced for ma'am to see. Just go and audit your clinic tomorrow. You'll be ashamed if you audit. But we don't audit, na? Audit karne se to gabad ho jayega. Look at blood pressure control. It's difficult. Controlling blood pressure in a diabetic is difficult. They require 3 or 4 drugs. Sometimes a mineralocorticoid receptor antagonist. Only 50% have blood pressure control. And lipids, one would think, is the easiest thing to control. Look at that, 40%. This is Indian data. I hope you have read the top part. I'm not taking you through everything. Treatment of end-stage kidney disease, let's leave it to ma'am. I mean, I don't know. Now I'm going to secondary prevention. Secondary prevention includes all that you have to do for primary prevention. Sugar, blood pressure, cholesterol, diet control. Don't restrict protein. I totally agree with him. Indians are protein deficient. All of us in this room are protein deficient. Then comes pharmacotherapy. And you have seen this slide before. I have made this slide. I have not copied it from anywhere. On the top is ACE-ARB. I'll not take you through mechanisms because she's taken you through. Pillar 2 is SGLT2 inhibitor. Pillar 3 is finerenone. Tomorrow, if you see a patient with CKD and you don't have these 3 drugs, ask yourself why. GLP-1, if you don't write, I can understand. It's very expensive. And there's only one trial so far, the flow trial which you saw. Other than that, we don't have only data with one RCT. But if your patient is not on an ACE ARB, please ask yourself, क्यों नहीं है? If they're not on an SGLT2, please show me that there's a contraindication for not writing SGLT2. Finerenone, if you don't write, I can still accept. It's still quite an expensive molecule. Costs 90, 95, 4 rupees per day. So these are the trials. Dr. Arvind, I think, took you through some of the cardiovascular outcome trials, which had secondary outcomes as renal outcomes. These are the primary renal outcome trials. Whenever you see a trial, there's a primary outcome and there's a secondary outcome. When you see a secondary outcome, the statistical power is not that good enough. So secondary outcome is always hypothesis generating. So you need to do a primary outcome study where the renal outcome is the primary outcome. And these are the trials. There are two trials with ACE-ARB, IDNT and renal. And look at that, from 2001 to 2019, 18 years. I think not less than $5 to $6 billion have been spent in these 18 years on 7 or 8 molecules. I will not take you through, and they've all failed. So when SGLT2, canagliflozin, was the first one when it showed positive trial, mind you, everybody in credence trial were diabetic patients. It was a big breakthrough in management of DKD. And then came DAPA-CKD and EMPA-CKD. And then you heard Fidelio-Figaro and you heard the FLOW trial. So my job has been made easier. I have to focus only on the EMPA kidney trial. Now, that was the general part of the lecture. Now we go into nitty-gritty. So anybody who does not like to read about trials, hear about trials, go for a coffee. But I will be diving quite deep into the trial. What is EMPA kidney trial? It was a phase 3 randomized, double-blind, placebo-controlled trial. So both arms did not know who's getting EMPA, who's getting placebo. What was the aim? To investigate whether EMPA reduces the risk of kidney disease progression or CV death. यही problem हो गया, लोचा यहीं पे. This is the problem with randomized controlled trials. What I want to know is, will the patient have acute renal failure, chronic renal failure? Will he die of cardiovascular death? But they never do with one outcome trial, one outcome. Na? They always combine it. Kidney disease progression. And look at the definition of kidney disease progression. The primary composite outcome. Can you read it, or is it a little bit hazy? Huh? Okay. So if you see, the primary composite outcome was CV death or kidney disease progression. And how was kidney disease progression defined? Kidney function loss defined as sustained loss in EGFR more than 40%. We can be in this room for the next 1 hour discussing this 40%, 50%, and 57%. Nephrologists still don't agree which one to use in their trials as the primary endpoint. 57% is where is serum creatinine doubling. Most of the kidney trials initially used to do doubling of serum creatinine. That is 57% decline in EGFR. That's why when you see the meta-analysis later on, I'm not going to there, they've already tried to do that, 57% reduction. Here they use 40% reduction. I don't know why. What, one fine day somebody woke up and said 40%. Or EGFR less than 10. On the right-hand side, end-stage kidney disease, which is easy to define. It is people who are starting chronic dialysis or kidney transplant. Very few people have renal death. They all have cardiovascular death. So if you see, there are only 3 or 4 renal deaths. There were secondary endpoints. I will not go into that. This is the different part from the DAPA kidney study. Look at the inclusion criteria. Inclusion criteria was DAPA also had 45-90, ACR more than 200. But the specific thing about EMPA kidney was they went down to EGFR of 20 to 45, and here it was irrespective of albuminuria. So I'll show you what percentage of people not everybody was of albuminuria, only a very small percentage, but that small percentage also is quite a huge number. And that's if you see here now, the age was 64 years. Doesn't apply to us Indians here. How are kids going to renal failure at what age, ma'am? 40, 45? That's the patient you see. This is Western data. There they go, heart kidney failure at 60, 64. Only 2 trials had more than 50% people without diabetes. So SGLT2 inhibitors not only used in diabetic CKD, but they're also used in non-diabetic CKD. That's why nephrology says it's their molecule, and so do cardiologists. So only 46% people had diabetes, and history of cardiovascular disease was only 27%. This number is important because when I compare with DAPA CKD, this number will come in. Look at the estimated EGFR, 37.4. And if you see EGFR less than 30, 1/3 of the patients, this is the largest SGLT2 trial which was so enriched with people with such bad renal failure. EGFR was less than 30 in 1/3 of them. And if you look at the ACR, that other box there, people having no albuminuria, I mean, so it's called A1 now, ACR less than 30, about 600 patients in each arm. That is the largest. No other trial has been done in people with diabetes or non-diabetes with EGF, ACR less than 30 with those numbers. It's only 20% of the whole trial, but the numbers are already quite huge. Another difference between DAPA CKD and EMPA CKD is the number of people who were on ACE ARBs. Every type 2 diabetic who has got EGFR less than 60 should be on an ACE ARB unless and until contraindicated. What they did was they enriched the population in such a way that 15% of the people would not be given ACE ARB for various reasons. And 15% sounds less, but look at the number of people who were not on ACE ARB. So these are the differences of EMPA CKD with DAPA CKD. So EMPA CKD had a big chunk of people with CKD who were not on ACE ARB. So here SGLT2 becomes the primary treatment for CKD, whether it be diabetic or non-diabetic. So straight away the indication for SGLT2 inhibitor becomes quite expanded with the DAPA CKD. What was the plan? It is always, those of you who follow RCTs are always event driven. It's already calculated before the trial starts based on statistical calculation. So it was supposed to be event driven, more than 1000 events over a period of 30 to 48 months. They had to stop it early. Whenever you do RCT, you have to have an interim analysis, and that is statistically driven. Why? Because if a drug is showing benefit, you cannot medico-legally continue the trial, because if you're continuing, you're going to not be able to give the drug to the people who will benefit. So that's not allowed, which is a sad part really. If EMPA kidney had continued for the full duration, then we could have seen the benefits, which I'm now going to show you as hypothesis, which has come out from the EMPA kidney trial. And this is the picture slide. This is the relative risk reduction, 28%. And remember, it is combined. You can't say this was CV death. You can't say this was more than 40% EGFR reduction. You can't say EGFR less than 10. All four outcomes put together, there was a 28% statistically significant reduction. Never, whenever you see a randomized control trial, don't go by this RRR. It's always inflated. What you should calculate is ARR, which is absolute risk reduction, which is very simple. Is the percentage of events happening in the EMPA arm minus the percentage of events happening in the placebo arm on the top. You just minus it, and that is ARR. You divide 1 by ARR, that gives you the number needed to treat. So what does EMPA kidney tell you? You have to treat 28 people with CKD with empagliflozin for 2 years to get primary endpoint, which is either reduction of EGFR less than 40% or GFR going below 10 or having a renal death or starting dialysis or renal transplant. So that is in nutshell what EMPA kidney trial gave you. Then there were many other things which were there. I will leave because of shortage of time and because of complications. I will leave the secondary outcomes. This graph you saw many times. Whenever you start SGLT2 inhibitor, your GFR will drop anywhere between 3 to 5 ml per minute, and that's what you're seeing. And after that, if you see the EGFR for the EMPA arm, which is in the orange, and the placebo arm, which is blue, the blue arm keeps going down. The EMPA also goes down, but not that steeply as the blue one. So whenever you calculate EGFR, if you read nephrology literature, there will be two kinds of EGFR they mention in RCTs. They'll mention something called as total EGFR, and they will mention something as chronic EGFR. So total EGFR is if you start from the top to the end, but this is going to happen with SGLT2. So people do not calculate that. They take what I've highlighted. They take what is called as long-term EGFR or chronic EGFR. And there if you see, there is a 50% benefit when you give empagliflozin to people with CKD. And that brings, I'll come to that. We can leave these parts. So this is in summary what EMPA kidney trial showed you. There were 54% people without diabetes, 35% people, which is huge number, 2,280, who had a GFR less than 30. There were 3,000 people who had A2 albuminuria. 73% patients did not have a cardiovascular disease. They had some secondary analysis. They saw what is the etiology of the kidney failure on the outcomes. And I will just show you the summary slide. EMPA kidney did not only have people with diabetic kidney disease, they had people with hypertensive kidney disease, renovascular disease, various forms of glomerular disease. So this is another aspect of EMPA kidney where it broadened the indication for SGLT2 inhibitor in people with CKD. This was a slide which ma'am was referring to. This is a kind of a hypothesis generating slide from a secondary analysis. If you just look at the percentages, it's a busy slide. So just look at the right column on the percentage which says relative slowing of eGFR decline with EMPA versus placebo. Look on the top side based on UACR. If UACR is less than 30, if you're starting empagliflozin, then look at the reduction, the benefit, 86%. Come down below, look at the etiology of the various causes of CKD, diabetic, hypertensive, glomerular disease. Even here you have almost 40 to 50%. If you see the last number which says 50%. So you prevent the decline of eGFR by 50% over 2 years if you give empagliflozin to people who have got CKD. And this is further extrapolation, okay? And just see those boxes on the top. It tells you time to kidney failure is the graph, and those boxes tells you delay in time in years to kidney failure. Most of the time we are starting SGLT2 inhibitors too late. We are starting SGLT2 inhibitors on the left hand side. When eGFR is 40, 45, ACR is 400, 500, 600, even there you're delaying about 1.9 years of ending to end stage renal failure where she has to start dialysis. But look, if you are starting it much earlier, person with type 2 diabetes, 3 years of diabetes comes to you with a GFR of 80 and an ACR of 32. We won't even think of that SGLT2 will prevent kidney damage here. That is where you should start. Look at the number of years you're going to prevent kidney failure, about 26 odd years. And that results in huge reduction in the number of hemodialysis. I mean, if you start at 85 ml, you will prevent 4,000 hemodialysis sessions. Can you imagine that? Now, the last 3 minutes that I have, questions always come comparing EMPA kidney with DAPA kidney. Because we are all used to using DAPA because DAPA got off patent 4 years ago, it became cheap. And unfortunately, I think most of you in this room use dapagliflozin. EMPA is also going to go off patent in another few weeks. We are having ad boards here as to how many companies are bringing empagliflozin at the same price as DAPA or maybe cheaper. Now you see the difference what EMPA does to the kidney as opposed to DAPA. There were lower ACRs. DAPA did not have that. Everybody in DAPA CKD had an ACR more than 200. So they had not really macro, by definition is more than 30, but now we have gone off from macro. We say A1, A2, A3. So everybody in the DAPA kidney had ACR more than 200. So if you're a purist, and if you see somebody with CKD with an ACR less than 200, you should be using empagliflozin. eGFR values are much lower. I told you, more than 1/3 had eGFR of less than 30. Much larger proportion were not on RAS blockade. So you can think of monotherapy. If you think of monotherapy between DAPA and EMPA, you should be choosing EMPA over DAPA. These are a little bit too difficult. Lower prevalence of diabetes, largest representation of people with non-diabetic CKD, lower prevalence of CVD. I told you, this will come into discussion. Why? Because everybody says that Dr. Mukherjee, look at what happened to cardiovascular outcome in the EMPA kidney trial. In the EMPA kidney trial, there was no benefit with regards to death from any cause or hospital and heart failure or cardiovascular death. But that was seen in DAPA CKD study. So many people interpret it as DAPA is better than EMPA. That's absolutely wrong interpretation. So please, when you go to a meeting, see who's sponsoring the meeting. Huh? I'm sponsored by BI, remember. But I'm sharing science with you, okay? I don't speak for any company. I share science. So why is this difference happening? The difference is happening for so many reasons. First and foremost, the trial was stopped at 2 years. That's why the benefit in the cardiovascular outcomes could not be accrued. Number two, there were lower absolute risk of CV events. I glossed over those slides. 54% of the people in EMPA kidney did not have diabetes. People with diabetes have high cardiovascular events. Only 27% of CKD patients had coexisting CVD. And the biggest difference is in EMPA kidney, every type 2 diabetic patient with a GFR of more than 60 and who had an ASCVD was excluded. Why? Because EMPA-REG outcome has already shown benefit in that group. That's what unethical to have those patients. So EMPA kidney was highly, highly underpowered to show cardiovascular benefits. Another 60 seconds, sir. So the different profile of the participants does not allow us to compare DAPA CKD and EMPA CKD. If you go to any meeting and you're hearing somebody standing on stage and comparing them, tell them Dr. Mukherjee told us they cannot be compared, but they can be put together. They're complementary. Because now you see from EGFR 25, you're going to EGFR of 90, EMPA, DAPA together. You're going from no ACR, zero ACR, I mean, less than 30 to more than 200. So they're complementary. And we should have what you call as a meta-analysis. This is my last slide. We have been talking about SGLT2, SGLT2, SGLT2. These are the situations where you should not be using SGLT2. That's my only one request. Every patient comes to you tomorrow, should be on ACE-ARB, should be on an SGLT2 inhibitor, except if they have any of these conditions. Here you don't use an SGLT2 inhibitor. Type 1 diabetes, don't use. Do not start in people with eGFR of less than 20 as of now. But as ma'am said, if you have started when the GFR was 25 and kidney function is deteriorating to the time they start dialysis, you can keep using it. And by the way, DAPA HD trial is going on where they're using dapagliflozin in people with hemodialysis to show that they, not show, to check whether there's cardiovascular benefit there. Don't hesitate to stop SGLT2 for 3, 4, 5 days. If there's dehydration, if patient is going for a holiday, why trouble him or her? Stop for 3, 4, 5 days. You're not going to cause any harm by stopping. But if you don't stop, you may cause harm. Because you all talk about euglycemic decay. It's very, very rare, but these are situations where it happens. So I think that's where I will stop.